care systems, and how can we come up with a way to come up with sort of easy to implement and effective care models in that kind of practice setting that enables the kinds of outcomes you heard about today to be achieved. I think that's going to be a real challenge.
Yeah, Marilyn, yes. Yeah, comment?
I left one entire paragraph out that Hattie will kill me for very quickly. We found in the 1980s with our pilots and astronauts and other high-risk occupations that the coronary calcium score was our best predictor of events. And we had a regression equation that was ugly and complicated called the coronary angiography decision equation. And in that, the calcium score was the best predictor we had in our young, otherwise completely healthy appearing individuals. And as we used that since the 1980s, even the precursor to the current calcium score, we found that once we could identify that risk in somebody, talk about motivation. And so that fits into what Victoria is talking about, that if we can translate that to the general population, I think that there's something there for prevention.
Great, thank you. Marilyn.
And I did my 8-word innovation as well, which is we need to meet patients where they want to be met. And I think it's in speaking to what everyone has said, but in my 30-year career as a pharmacist who has been on the care team and has been embedded in the medical group, I sort of thought I knew where patients wanted to be met. And I have to tell you that I absolutely didn't. And I think that if we engage patients and ask them how they want their care and who they want involved in their care, we might be very surprised at what we hear. It's not us. It's their barber, it's their pastor, it's their neighbor who they trust, and that's why they take their neighbor's medicine. And so I think that we have to be ready. I'm a firm believer in disruptive innovation and organized chaos. I love change, and I think we've got to figure out how we get this paid for and how we get out on these care teams as teams. And I want to applaud everyone who's talking about the pharmacist on the care team here that wasn't even a pharmacist up here, and representing pharmacists who are in the audience and who've done great things for care. We've got to figure out how to get it paid for, because we are not the cheap person on the team. If physicians and nurses are too expensive in the United States, pharmacists aren't cheaper. So we've just got to figure out how we get the right person doing the right thing for the right patient. And when we figure that out, that's the holy grail. But I think we have to go to the patient and figure out where they want to be seen, because it's not the clinic, it's not the hospital. I'll guarantee you that.
Yeah, great. Thank you for that. So Matt. Yep.
You are so close. I am the last one. So this is great. I'll tell you, I could hardly add to the countless wonderful things that have been said today. It has been life-changing in some ways to me. As a family physician, the one thing that is amazing to me, I spent several years in executive medicine, and now I'm back to being a little bit more clinical. And it's amazing the myriad of things that come to me every patient encounter. It's a little bit overwhelming a lot of times, especially in a community health center when you've got so many other issues of mental health and substance abuse and other issues. And so as much of this that can be, I can be helped with, and I think our physicians are much more inclined to receive help than maybe what they had been in the past. The old mantra of it's up to me and I'm the doctor and I'm going to do everything is not so much the case. And so, you know, as I listen how Kaiser has, you know, the blood pressures will be taken and there's a checklist and the MAs are involved in this and that, and there's algorithms to where that kind of is taken, lifted a little bit from me, makes a big, big difference in those encounters that are focused somewhere else. But we all know how important these factors are. So that'd be the one thing I'd say. And the last thing I would say is I'm very grateful that Brian Hayes, who is the Chief of Staff, or Deputy Chief of Staff of the Northern California VA system, invited me to the Right Care Initiative about 5 years ago. And I've enjoyed every time I have come, and I've learned so much. And I know that there are many other leaders, there are many other changers, those who can lead change, that you may know. And it's wonderful to see different systems all working together. You know, we love healthy competition, but we also love best practices being shared and pulling people in. And so as if there are those that I may know that, whoa, they would be a great assist to what we are doing, I want to be like Brian Hayes and bring them to this. And so that's what I would encourage. And thanks, Hattie. Every time I come, she's showing me to introducing me to other people. And that's what we all need to be. That's wonderful.
Great. Thanks, Brian. Great panel. Let me just share a very brief story, which I think cuts across almost all of your comments. And some of you may remember or know Dr. David Sobel, who was at Kaiser Permanente for his whole career, and has written several books on patient engagement, health promotion, disease prevention, and so on. And David tells us one story. I mean, he's got a whole repertoire of stories, but the one that stood out in my own mind is a story. He was in a forum sort of like this a few years back, and he said, I personally have struggled over the years, and I've learned some of the things that you all talked about on the panel. It's not, what's the matter with you, but what really matters to you, and how do I get to a comfort zone with you and you with me, so you feel we can have that meaningful exchange. And he had a patient, just call him John, for years that he was never able to get through to John. John was overweight, he was diabetic, he was very depressed. And on this particular visit, Dr. Sobel said he was going to tell John that Dr. Sobel, was planning to retire in a year or so. And John, you need to start looking for another primary care doctor. And you and I have had a storied past. It hasn't worked so well. Maybe you want to look for a new, physician, etc. And he saw John get a little concerned about this. And so he finally gave it one more try. He said, John, at this stage of your life, what does really matter to you? We've talked around this for so long and no progress. And John finally said, well, I'm having a high school reunion in about 3 months, and they're going to go fly fishing in Montana. And, I would really like to see them again and do that. And John couldn't go on airplanes, his health, etc. Bingo! Dr. Sobel finally got it. He said, John, are you serious? Yes, I'm serious. He said, okay, if you want to do that, let's work together and you will be able to do that. Is that really important to you? He says, yes, it is. Long story short, he did. He went on it. He had a great trip, etc. So it's about what really matters to the patient in their life at that point in time. So I think the panel did that in a very good way. Lots of great examples. Let me just give a very brief summary, and then Hattie, turn it over to you on the awards and so on. But one of the things that I've taken away from all the marvelous presentations we've had today is the cross-cutting issue of implementation, of execution, day in and day out, is just comes across. And along with that is the reflection that, as we all know, we have a very high variance healthcare system in the United States. We have absolutely outstanding examples, and you heard some of them today, the Kaiser Permanentes of the world, the Intermountains of the world, the Health Partners of the world, and the list, could go on. But sadly, those are almost not even the middle of the distribution. They are the tail end. They are the high performers, okay? And so somebody said it earlier on the panel, the real challenge is going to be, what about the practices here in California that are not these integrated care systems, that are the IPAs at the tail end, Hector's data that he presented, for example, are the smaller practices, are in the rural parts of the state. You saw Dr. Wright's diagram with all that dark red was in rural parts of the state, the Central Valley, right, et cetera, et cetera. How do they achieve with their patients, working with them, some of the very good performance we're beginning to see in the integrated care systems? Not all of them are going to become these integrated care systems. How do we motivate? How do we use telehealth? How do we use some of the tools and adapt them? So that's another sub-theme with standardization today, standardization to the science and the process, customization to what it is patients really want. So it's not either or, it is both. From the very beginning of what Arnie presented and Chuck's experience, et cetera, and the Helsinki experience, what they did to figure out the steps to get that flow, right? Applying lean and other kinds of management technologies to do that. But it's not like, oh my God, you're taking away the clinical decision-making authority and autonomy of the physician. No, no, no. It's why don't we use the evidence-based science and figure out how to do things really smarter, and that's going to free up time to use your clinical judgment and really engage with the patient. So that's another theme I think that was throughout the day as well. And the final one that I really, maybe it wasn't evidence today, is going to be persistence. Persistence. You got to keep at this, right? You got to try things, you got to take risks. Not all of it's going to work. Some of it's got to fail. We got to fail more quickly, smarter, et cetera, et cetera. I'm kind of reminded, I'm reading now, or listening mostly, the biography of Grant, Ulysses Grant, right? Chernow's book. And his whole life, and many of us in this room, is you keep doing things and you fail, and you fail, and you fail. Grant certainly did. Before you find out something you're good at. He happened to be good at war, right? He was marvelous at war. Before then and after then, not so good. He's president for a while as well. But that's true for organizations too. You've got to experiment, you got to take chances, you got to be disruptive, find out till you get really good at something, and then you get going from there, right? And so we need to kind of persist in some of these efforts. And I think that's the great thing about the Right Care Initiative and the people in this room here. You are persisters. We keep going. When this started out, like the first year, I thought, okay, second year, and third year would probably be it, and we're off to running to other things. But we underestimated the persistence of Ms. Hanley over here. So with that, I really thank you, and I'm going to call on Hattie for the awards. So we're going to have some awards now. Do we do it here, down here?